This episode of Transmission Interrupted was recorded April 7th, 2026. This is Transmission Interrupted, a podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Welcome to Transmission Interrupted from NETEC.
Hello, and welcome to Transmission Interrupted. My name is Jill Morgan. I'm here at Emory University Hospital in Atlanta. For those of you not yet familiar with NETEC, our mission is to set the gold standard for special pathogen preparedness and response across health systems in the U.S. with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. NETEC works alongside and in cooperation with the CDC and is funded by ASPR, the Administration for Strategic Preparedness and Response. I am so excited today to be talking to someone who feels like an old friend to me. We are here today with Dr. Laura Evans. She is the brand spanking new Executive Director of the National Special Pathogen System, NSPS, as it's known across our world at least. She's also a professor of medicine at the University of Washington, and she has a lot of other accolades that we'll get into as we get to talk with her today. A little bit about NSPS, and I hope enough about Laura Evans that you will become as much of a fan of hers as I am. So welcome, Laura Evans.
Thanks, Jill. It's great to be here. I also just have to say that I love your intro music. It just sets the stage really well for the podcast. I'm really thrilled to be here with you in particular, because it is like talking to an old friend. And getting to do this podcast with you alone is probably reason enough to take the job as the executive director of the NSPS, because this is a highlight of the gig.
I would not recommend that to anyone as a job enticement, but
well, they just don't know you well enough yet. Yeah.
Oh, if you're a really nerdy person and like PPE and birds and trash and basic physics stuff, yeah, I'm got all that, but I don't have much else going for me. So I would love to help people understand how you got to this and what brought you here. Because again, I've known you for a long time only because you were this leader at New York Health and Hospitals, but really in the critical care world. I would just love for people to hear a little bit about your background. So as a critical care doctor, working at Bellevue, and then how we got to where we are today. And I'm happy to try to solicit out of you stories that I think are especially enticing.
I guess like all good things, right? Professionally, everything takes a little bit of a circuitous route, right? When I was in medical school or pre-medical school, if you said, you're going to spend a large proportion of your professional life thinking about special pathogens, infections, and preparedness, and how to keep healthcare workers safe while providing outstanding patient care, I never would have dreamed of that in a million years, right? And, a lot of it's sort of being in the right place at the right time, or if you're a contrarian, you could say the wrong place at the wrong time and having to respond to situations. And I kind of fell into it, but in a way that it really piqued my interest and appealed to me both intellectually in terms of the problem-solving components of it. And also throughout my entire life, I would say one thing that I have really focused on, and I think I kind of pride myself on being a core value for me, is a sense of teamwork. And so being involved in this space is sort of, to me, the ultimate kind of team sport. Critical care is a team sport, and then this is also an amazing team effort. It doesn't work if the whole team doesn't work. And that just intrinsically appeals to me as a human. I've always loved working as part of a team.
I love that. But I also want to say that for a lot of healthcare workers, I want to highlight what you just said, because it sometimes feels historically, perhaps in medicine, and I'm at the nearing the end of my career compared to an awful lot of younger people starting careers in healthcare, but it has felt more hierarchical and less of a team sport sometimes in certain places and in certain units or certain kinds of units. But I think you're absolutely right. You just said something that people who practice, at least in ICUs, whether they recognize it or not, patient care improves when we work in a coordinated fashion. right? So we do better patient care. We have better patient outcomes when everybody knows what the goals are and what we're doing that day and why we're doing what we're doing, and pitches in to make that work move forward. So I'm really grateful to have someone now in this position who has that mindset. So first of all, I just want to salute that, because I think it's unfortunately not common enough in medicine for me to just let you slip that in, that you really believe in team playing, because
Well, that's a bummer to me.
I recognize that too.
I think you're probably right, but that still makes me a little sad. You're so spot on, right? Being a part of a team doesn't mean we all have to do the same job, right? But it means all the pieces have to work together to the peak of our capacity and look out for one another and recognize each other's strengths and things that we're less strong at, and use the power of the multiplicity of us to do the best job for patients and our coworkers.
Yeah, absolutely. For people who don't know, can you tell them a little bit about the story of how you got involved in special pathogens at Bellevue? It will, I think, at least remind people of what was happening in the world at that time and how crazy things were.
Yeah, happy to. So I was at Bellevue from 2006 to 2019 professionally. And I think the first time I started thinking about emerging infectious diseases was really in the 2009 H1N1 pandemic. We've been around long enough, Jill, that we remember that really vividly, right? Of the rapid evolution of this pandemic, the impact of both the patient acuity on our volumes in the ICU and the numbers of patients themselves. That population was predominantly a relatively young population. And I think it hit us all pretty hard in the critical care community. And at that time, I was this brand new director of critical care at Bellevue and was tasked with thinking, like, how will we manage this surge of patients with an infection that we think the vaccine is probably reasonably good at, but may not cover super well. So what's the risk to ourselves and our community? How are we going to handle potentially higher levels of patients and the acuity of those patients? And that's where I sort of really got into thinking about specifically higher consequence infectious diseases in an intensive care environment. And I felt a little on my own, quite honestly, right? I was kind of had finished fellowship 4 years before. I was now the critical care director at New York City's public hospitals and trying to figure this out. And I was trying to build a community of who can I go to for help from this. And fortunately, through the Society of Critical Care Medicine and some other networks and things like that, I ended up getting put in contact with people who had done some good thinking in this space. And I'm very grateful to folks like, I'm going to name check Perrin Cobb, who's at the University of Southern California, who's not explicitly involved in the special pathogen space, but helped me get into this sort of space of public health emergency response. We got through the 2009 pandemic and things were relatively blue skies, okay. And then in 2014, started hearing about this large outbreak of community spread of Ebola virus disease in West Africa. And being in the heart of New York City, we probably had at least as elevated sense of risk compared to many other locations, and started doing some preparation at the hospital from that. I was really fortunate. I was the medical director of critical care. We had amazing levels of hospital commitment from that. And you, Jill, you've met many of these people who are involved in the hospital level response from that. And they're really cool and special people. And so the level of commitment from the sort of executive administration of the hospital was really wonderful. And Bellevue has had a very long and very storied history of infectious disease response and collaboration with New York City's Department of Health and Mental Hygiene. And so it really just played, coming back to that team space theme, it sort of played to our strengths, right? That we had this long sort of sense of teamwork. We'd had prior responses to tuberculosis and specifically multi-drug resistant tuberculosis, to HIV epidemic, and then going back further in history to yellow fever and some of these other responses that Bellevue was very involved with in collaboration with our public health partners. And it became pretty clear early on that because we were a small community, because of that sense of teamwork, that we thought critical care was kind of the right clinical owners, quote unquote, for that special pathogens response from the clinical perspective, not from the infrastructure operations perspective per se, but from the clinical response. Who's going to take care of these patients? We said we should take a high functioning team that already works really well together And if we're going to put them in a stressful new environment where we're changing locations and having them respond to patients where they haven't cared for a patient with Ebola virus disease before, there is a sense of what is the risk to me individually as a healthcare worker of being involved in this care. And we've sort of said it's probably best to take a team that functions really well and have them respond as a team rather than try to remake that teamwork with a new composition of people. And so that's how I ended up involved with it. And I think back to Dr. Nate Link, who was the medical director of Bellevue at the time. And he famously said something to the effect, I'm going to paraphrase it, I'm going to do it poorly, but he said something to the effect of, there's been many things we've prepared for here that have never happened. There's been many things that happened that we never prepared for. And this particular constellation of preparing for Ebola virus disease and then having it happen was a relatively rare entity where something that we prepared for actually happened.
Yeah. And I think that it demonstrates so many properties that I think we have people across the country who are thinking like you're thinking or were thinking then, but they may feel like they're, like this tiny little candle in the wind, right? They may not have the administrative support or they may not have the position that lets them elevate things, but they're out there doing their part to try to make their space prepared. And it can be so difficult. You can feel like you're just never going to make progress and never going to get there. But here in this situation, you had this foresight, you had a supportive administration, you had great public health support, you had a history within your institution and your city really for responding to all sorts of horrible disasters. And then you had a patient who was out taking care of people in another country, is brought back home, feeling okay, but isn't okay. Suddenly, Bellevue becomes one of the places that treats some of the first Ebola patients in the country.
Yeah. And I thought it was a drill.
Yeah.
I thought it was an exercise. I thought that Dr. Spencer was a mystery patient exercise. And then he let me draw his blood. And I was like, well, that's probably not a drill.
This is where you're starting to concern me. No, that's great because it's true. You think of all the things that we practice. We do fire drills and we do full-scale exercises of all kinds. And even just how many people take ACLS and are doing mega codes and all kinds of things that they never end up seeing some of the rhythms or some of the problems that they practice for. But we know that kind of thing does prepare us, that we feel better when we're in this situation because of that groundwork that we did. You talk about being in the right place at the right time. You've had some experience with some other disasters. I don't want to say that people should avoid where Laura Evans works, but perhaps.
It's been said before.
You have either been in just some bad luck situations, or maybe you are one of those people that respond so well under pressure that you got through these things very well, right? I mean, I would love for you to talk a little bit, just because it's a funny story, about funny in that it's funny from a distance, like a lot of disaster stories are. But I think there happened to be a bucket brigade from the basement of Bellevue.
Yeah. Just exactly a year before the 2014-2015 Ebola epidemic. Folks who remember that time, there was I think it's still debated whether it was truly a hurricane or some other combination of weather events, but they called Superstorm Sandy or Hurricane Sandy that hit the northeast coast of the U.S. The basement of Bellevue Hospital, which is situated right on the East River at about 28th Street, flooded. And we were all kind of in the building prepared to respond. And so I had my thermarest from camping in my office floor ready to take a nap when I could. My dear friend and colleague who apparently probably travels much nicer than I do brought a queen size airbed into his office with 600 thread count sheets. I was like, how come I brought my camping mattress? But the hospital lost power due to flooding in the basement. We lost the elevator service in the hospital. And then Bellevue is about a 20-story building. And in order to keep the backup generators going, because the fuel pump, the backup generators are obviously elevated above flood level, but the fuel pump that fueled the backup generators was located in the basement. So the fuel pump flooded. So the generators would work, but there's no way to get fuel to them. We were just in the ICU caring for patients and thinking about how we would evacuate them. They formed an ad hoc bucket brigade that had a fire truck. So the fire department of New York brought a fuel truck outside the hospital, and they were basically a human chain ferrying buckets of fuel through one of the stairwells up to the backup generator. And, there's photos of this event, but it was really an amazing team response, right? Because you had everybody from, the photo I have of it is the chief of internal medicine of the hospital, medical students, electricians, you name it, the IT support staff. But it was just in the stairwell, literally passing buckets of fuel up the floor. And then to culminate it, it had to go up a step ladder and then get poured through a funnel into the backup generator. But through this, they managed to keep the backup generators on when we expected to lose all power, including backup power, within a matter of a couple hours, which would be catastrophic for a hospital. We had veteran nurses who remembered how to count drips on an IV pump, right? Because the IV pumps wouldn't work. They have a very short backup battery. So we had, I can't remember the term for the thing that counts.
Dial-a-flow.
Yes, thank you.
Yeah, a dial-a-flow. Yes.
And trying to calculate how to give the appropriate dose of vasopressors through a dial rather than through a modern IV pump was a wild experience. So we were kind of grappling with that. But they kept the backup generators long enough that we could evacuate all the patients safely from the building, down the stairs of a 20-story building. It was quite remarkable.
Yeah, remarkable. It really is. I think a lot of hospitals prepare for emergencies of all kinds, but y'all got hit with so many different things all at once, right? So a power outage is one kind of thing, but also having things flooded and not being able to use any kind of, it's an amazing feat. But it really speaks to your first points, which are the importance of teamwork and the importance of having people that you can depend on and that you also help keep safe. And I think that's a great theme as we move into this part of your career, right? This idea of now leading this National Special Pathogen System. Can you sort of talk about what parts of this job really grabbed you, made you want to do them, and where you see things going? Maybe next steps sort of thing with NSPS.
Yeah. I think one of the things that really grabbed me about the role is the concept of trying to build a system that's nimble and responsive when you don't know all of the details, right? You don't know how everything's going to work. You don't know what the scenario is necessarily going to be. So trying to build a structure or help build a structure, obviously with a big team of people across the country, and federal partners and healthcare partners and public health partners that can be responsive and adaptive, right? It's like one of the things that I've learned from these other very local responses is that it very rarely rolls out exactly how you think it's going to, right? And so you have to have a structure in place where you can adapt on the fly. You can write the world's best plan, and it's a great outline of a place to start, but almost nothing's going to roll out exactly as you've sort of imagined it. And so trying to sort of think about that type of problem, but on a scale of the United States is a really huge challenge. One that I find both incredibly exciting and honestly very daunting as well, because it's not going to roll out exactly as we think it is when the next event happens, but trying to help get the pieces into place so that we can have that sort of coordinated, cogent response and that ability to be adaptable and get it done in the moment. I think it's a really big challenge to me. That's clearly stepping into a role that was filled by Shelley Schwedhelm from Nebraska, who's an extraordinary leader and had a really groundbreaking vision for how this could work, is also really daunting, quite honestly, right?
Yes, Shelley was a force. Yes, absolutely. And hearing you say that, we just did a podcast not long ago with Vance Farabee. Vance mentioned that you could train, and you should train, obviously, and prepare people. knowing that the situation you encounter is never going to match what you trained to, and that you have to trust that you've trained to some general principles, that people understand them well enough to be able to apply them to that situation.
Exactly.
And certainly whether you're on a plane landing somewhere and you don't know how your patient's going to be packaged or what the country is going to even be like, to a situation with a disaster or infectious disease outbreak where do we know the pathogen? No. Do we know what kinds of things are going to be contaminated or infectious? No. But if we have the fundamentals, then we can respond and at least err on the side of caution and protecting people and staying safe enough to deliver, as you said, great care. That's what we're trying to balance. How do I stay safe? How do I keep our environment safe? And how do we deliver the care that we're really here for?
Exactly. We talk a lot about the one patient at Bellevue that we had with Ebola, but we don't talk about all the other patients that we saw who had some risk. They had some epidemiologic risk or some symptoms that could be concerning that didn't have Ebola. They had other conditions that needed us to treat them and respond and take great care of them. That to me is one of the really core elements of having this system, right? Is that most of the patients we evaluate as part of this special pathogens response probably don't have a special pathogens infection. They have something else. And we still need to diagnose and care for that. We can't let our degree of concern or fear sometimes, right, in responding to somebody that we think could have a special pathogens infection, prevent us from taking care of the person in front of us.
Right. I was an ER nurse a very long time ago, so things have changed some, but every ER sees people with chest pain. Not all of those are heart attacks. And one of the toughest things when somebody presents with chest pain in the ER is doing that rapid questioning. And we probably don't all have the same questions we ask, but we're all trying to get to the same answer. Like, how can I rule out a heart attack? How can I rule out the stuff that will kill this patient very quickly and get to the stuff that I might still need to treat, but that I can treat once I make sure the rest of this is ruled out?
Exactly.
I mean, somebody coming in with chest pain could have a PE, they could have a collapsed lung, they could have, there's almost no end of what they might have. And so when people are like, well, how do we rule out an infectious disease when people can have all these very basic symptoms, influenza-like illness, it's also vague? Well, you're right. So can chest pain be vague. And you have to get your questions down that let you winnow through these. Travel is a great one. Exposure is a great one. All the others are epidemiological risks. But we have the ability to do this. And I really like the idea that we're on the cusp, maybe, of creating this system. I certainly worked in an ER when we didn't have good trauma network connections, and patients didn't have good outcomes if you can't get them where they need to be. And I think that's the goal of NSPS to me, is getting people where they need to be.
Yeah, I totally agree. I think one of the brilliant things Shelley and the original contingent for NSPS did was really align it in this tiered structure that we use for other response networks. You already mentioned trauma, right? You align it to sites that have higher levels of capability and more resources and a great wealth of subject matter expertise. And you build this kind of culture of mutual support around it, which I think is really key. And I love it that it kind of fits in with other emergency response situations in our healthcare system. Because when you think about, going back to your earlier comment about, we're not going to train for every specific circumstance, and what we respond to is never going to be exactly what we train for. But when you sort of lay out the substrate and say, we have the basics down, we have this foundational work, and I have the skill set to respond and to adapt as needed, then I think aligning it with other networks that we've done this type of work, it sort of has this beautiful elegance to it, right? Because it really anchors with what people already kind of know and understand. Trauma did a lot of this hard work already, right? Sort of building out the trauma care system and defining level 1 centers and level 2 centers, and what do the verification processes look like, and how does this all interrelate? And so it's conceptually pretty easy for people to apply that same kind of framework to a special pathogens tiered network response, which I kind of love the way that it aligns really well across other responses as well.
Yeah, No, I agree. It does feel more intuitive than if we had tried to create something completely in a different sort of format, if you will.
Yeah.
But having said that, are there pieces that you think are not just a little, obviously this is something everybody's struggling with right now. Nobody's got it 100% right, even those of us who are at what we call RESPECTs or Regional Emerging Special Pathogens Treatment Center. There are 13 of those across the country, which is not nearly enough. Now we have these rising level 2s that are facilities that have volunteered to step up and say, yes, we will get better prepared, and this is what we're doing to get there, and we could take care of a patient for the extent of their illness, as long as they probably don't need really dramatic things. And I'm grateful for those pieces to be in place, but I wonder if you see topics or areas that are challenges even above just the baseline challenge. Are there topics or areas that you think, okay, if we have to pick one or two to really focus on, this is where the greatest need is?
That's a tough question. I think you used the phrase already, this sort of like incipient network, which is probably a pretty apropos description of where we are, right? We have a conceptual framework for the NSPS, and there are established level 1 centers, the RESPECTs at which you referred to. And then we're recently able to, through funding from ASPR, offer some support to help increase the capacity of designated level 2 centers. And so now there are 54 awardees who are really rapidly working to build the capabilities of level 2 centers, which will, as you said, sort of take care of patients for the duration of their illness if they have a special pathogens infection. And there are probably too few of those as well. But to really be functional, right, the network needs to have a full complement of what we're calling level 3 and level 4 facilities. And that's quite honestly a little bit of a difficult argument sometimes, right? Hospitals have lots of competing priorities. We're in an era where hospital operating margins can be very thin, particularly hospitals in rural areas are having trouble with serious financial troubles under best case scenarios. And then saying, I want you to allocate some resources towards an event that quite honestly is probably rare, is a bit of a difficult conversation to have with them. And, we're taking some really hard looks within the NSPS and NETEC leadership to say, what is our best sort of entree to getting hospitals across the US to want to join this network? And how do you provide support to them? And what resources do they need to do this and do this safely? And to be really blunt and transactional about it, what's in it for me argument to a hospital that perceives themselves to be low risk and has other competing priorities. Traditionally, we've hinged that on almost like an insurance model, right? Like it's probably a rare event, but if it happens, it could be really bad. We also know that people don't always get insurance, right? Even if they perceive themselves to be low risk. And so I think that's one of the big challenges. If we're going to demonstrate this network to be successful, that's a problem that we have to solve.
Yeah. I, of course, have some ideas that we'll take offline. Maybe.
Awesome. I love it.
I think the other piece that jumps to mind is that a system isn't the same as 54 plus 13, 67 discrete points, right? And one of the things that we know we need is transport support. Like we have to have an EMS system that can move people from your frontline facility. There isn't just some miracle. And even though we've talked to Phoenix Air and the government, it's not a situation where they're just going to immediately bring in an airplane or a helicopter or anything to whisk this person away. That means your local EMS, your state EMS, somebody has to be working on the preparedness to move these folks. And that's a big piece.
Yeah, it's a huge piece, right? Transport considerations are huge, and they're huge even when you're talking about relatively short distances, as you said, with local or municipal EMS services. And then you can compound the level of difficulty of that when we're talking about long transport distances. I moved from the heart of New York City to Washington State. I live in the city of Seattle, which is clearly a major urban area. But I can tell you the distances, there's a lot more space between cities than there was, on the Northeast coast. It definitely makes some big challenges of how do you move people to regional centers across very long distances.
Absolutely. We have the problem of distance and moving people like that. We have Still the problem of overall capacity. If you have been on an airplane lately, you know that they're filled. I think in the South, we'd say cheek to jowl. You are just filled up in there. You're sardines in an aluminum tube. I think about how many hundreds of people are on an airplane. What would we do if we had an exposure, or not just an exposure, but people actually symptomatic after a visit somewhere? And of course, with the World Cup coming up, I think that's a big deal. How do we do this preparedness, thinking about the influx of visitors? Not that the United States doesn't have visitors all the time. We have hundreds and hundreds of international flights on the daily. But this is going to be concentrated in some cities, and I just wonder what you think about our level of preparedness now. And I think we're going to have an opportunity, I hope, shortly to talk more about World Cup preparedness. But I just wondered if you wanted to say anything about that today.
One, I'm really excited for the World Cup as a soccer fan. So there's a lot of work going on, both visible and behind the scenes. There's a lot of work going on. What I really hope comes out of it is that, and I know you would echo this as well, Jill, is the idea that we use these events as opportunities to move the whole field forward, right? To raise the sea, right? So that all the boats rise, is that we use these as opportunities, not just challenges and threats around it, but as opportunities to make us more prepared. Because who knows if something's going to happen, we might see something with the World Cup, or it may not be associated with a major global mass gathering. It may just be part of routine life in 2026 or 27, or you name the year. But I really hope we can use it as an opportunity to keep meaningfully moving forward towards this aspirational goal of a network that really does cover everybody in the U.S. in a reasonable time frame and allows us all to take what we got into healthcare or emergency medical services for, or emergency preparedness, to take good care of people and be safe.
Yeah. I love that message. And I love how that sort of ties back into your very first messages today about the importance of being a team player, not just as a phrase, because we hear it a lot, but as the way somebody walks the walk. To me, being a team player, thinking about how we do the job we came to work for, the reason we went into medicine to start with, while keeping each other safe. And I think this is something COVID is still sort of nightmarish for a lot of us. We realize that we didn't do enough in some cases to keep staff safe, or we didn't have enough PPE, or we didn't teach people, or we didn't have the right messaging. And part of that is that we just had so much we didn't know. But I'd like to think, as you said, we're moving forward with this idea of a national special pathogen system that has these aspirational goals of giving the best patient care possible without negatively affecting the healthcare workers that make that happen. That's a fantastic thing. But this is no small potatoes lift. And I could not be happier that they've chosen you to take this role. I love the idea that somebody with those kinds of values and forward thinking is at the helm of something that might influence the safety of myself and other nurses and healthcare workers across the country. So I'm thrilled that Dr. Laura Evans is now the executive director of the National Special Pathogen System. And I really appreciate you taking a little time out of your very, very busy life to talk with me here on Transmission Interrupted. And I will give you another minute to say anything else or to restate anything you would like for Benjamin to magically work into our podcast.
It has been a pleasure, Jill. I'm delighted to be in this role and unspeakably delighted to get to talk with you in this capacity. You just mentioned sort of the aspirational goals of NSPS, which I think are amazing, as you said. And we're all familiar with this image of Sisyphus, right? Pushing a boulder up a hill. And there are several, modifications out there, but I always prefer the one that has a group of people helping Sisyphus push the boulder up the hill. Some are pulling, some are pushing, some are supporting Sisyphus. And that's kind of how I envision the work of the NSPS. Is there are challenges, there are headwinds, but the goal is worth getting to. And I think if we work together to get there, we can meaningfully make some progress towards getting there. So it's been really fun to be here. Thanks for inviting me.
That's great. Well, thank you, Dr. Evans. Thank you for joining us. For those of you listening at home, thanks for tuning in. We hope you'll join us for future episodes on a wide range of topics. Healthcare worker safety, hopefully more about NSPS, World Cup, all sorts of timely things like that, but also my favorite topic, personal protective equipment, infectious diseases, you name it. If you have any questions for NETEC, ideas for future shows, please feel free to contact us at info@netec.org, or you can find us on the web at netec.org/podcast, where you can also subscribe to future episodes and find out more about today's topic, Dr. Laura Evans. So, thanks for joining us, and we'll see you next time on Transmission Interrupted.
You've been listening to Transmission Interrupted, a NETEC podcast, produced and edited by Benjamin Madsen, with additional support provided by Britton Clark, Veronica Lavaro, Jason Noble, and Lisa Stone. Special thanks to our guests and the subject matter experts at NETEC for their insight and guidance. This podcast is supported by the Administration for Strategic Preparedness and Response. For more information, tools, and training on special pathogen preparedness, visit netec.org. And don't forget to subscribe, rate, and share the show on Apple Podcasts, Spotify, or wherever you get your podcasts. Thank you for tuning in to Transmission Interrupted.